Hello and good morning to everyone. I hope everyone is excited to listen to the two excellent talks we have this morning. Very, very interesting topics. So I will lead by introducing Dr. Fu Jen Chun. Dr. Fu, or JC as we call him, is proud to call his alma mater. He is a consultant pediatric oncologist who did his training both locally and more recently at the Hospital for Sick Kids in Toronto. His special area of interest is brain tumors, and this morning he will share with us an overview on inherited cancer syndromes. So over to you, JC, the floor is yours.
Okay, thank you, Prof. So I'm going to quickly share my screen. Okay, so I hope you can see the screen well. Okay, I was just start. Okay, so yeah, good morning. I'm Fu from Pediatric Hematology Oncology Unit. So from today, this morning, from a point of view of pediatric oncologist, I'm going to share with you an overview of cancer predisposition syndrome. So in this 25 minutes talk, I hope I can actually convince you that this is actually an important topic, as most of us in the clinical field, in no matter what specialty we are in, I think we will somehow see patients with neoplasm or cancer in any form. So I hope that this will also remind us that to actually look for inheritable cause in any of those primary cancer. So just my disclosure, a bit of introduction, considering the range of the audience here. So just to recap some of the important ideas. So the neoplasm or cancer is actually at its root a genetic disorder, actually, due to mutations leading to imbalanced cellular growth, proliferation, and also death. So most of the cancers, they have this mutation in what we call a single post-zygotic cell, or this mutation actually happens after fertilization, meaning that it is not inheritable, and then we call this as a somatic mutation. And then most of the time, these mutations can be due to intrinsic cause of DNA repair issue, or extrinsically due to stressor from externally to the cell. So sometimes this mutation happens in gamete-forming cells, and then they are inheritable. So, and then we call this as germline mutation, and this is exactly the area that I'm going to actually share with you and talk to you this morning. So more than 10% of pediatric cancer patients actually harbor a germline mutation in cancer predisposition gene, and then we believe that this is most likely actually underestimated because of the detection. So these mutations leading to neoplasm or cancer, they have various names. Some people call it as cancer predisposition syndrome, or CPS, or genetic tumor risk syndrome, cancer susceptibility disorder, cancer genetic susceptibility syndrome. But generally, they are all similar. So by knowing all these things, and then also the mutations, that give us insight in knowing the disease mechanism, the phenotype, the clinical features, and also the biologic mechanism of tumor formation. And with that, hopefully, we can actually understand how the tumor forms, and then how we can actually target them. So generally, how do we actually make a suspicion initially out from a diagnosis of neoplasm or cancer? So with initial presentation, and very, very importantly, a good 3-generation family history, will get maybe initial clues for that. So on your leftmost column, you can see that sometimes the presenting features of a tumor will suggest a possible diagnosis of cancer predisposition syndrome. For example, a sentinel cancer, meaning that some of the cancer are highly suggestive of a cancer predisposition syndrome. For example, like a choroidal plexus carcinoma, or adrenocortical carcinoma, and then it's actually highly suggestive of, for example, Lee-Fraumeni syndrome. Sometimes when you have a cancer involving both pairs of organs, for example, retinoblastoma or Worm's tumor, or if, let's say, the tumor is actually happens in an unusual site with an unusual histology, or multifocal tumor, meaning in one organ it has actually multiple tumor in one organ, or multiple primary tumors with different histology, for example, in replication repair deficiency, then you need to actually suspect whether there's actually cancer predisposition syndrome. Sometimes we do not have all this information, and then we do not have even a family history. When we look at the biological sample, sometimes we notice with various techniques, we find somatic mutation in the tumor. So for example, we stain for MMR protein, as you can see the pictures here, and then we stain P53, and then sometimes that leads to a suspicion of a germline mutation, and then therefore we proceed with the germline testing, and subsequently we make a diagnosis of cancer predisposition syndrome. So this is a recent case that we have. This patient has no family history, and then because of this entity of pediatric high-grade glioma with MYC-N amplification, retrospectively we know that we need to actually screen this patient for Lee-Fraumeni syndrome. So up until this point, maybe you will ask, we are not oncologists, and then what is the benefit of us actually knowing this? And then I think exactly this is the point why I actually need to draw attention to, because some of you might have actually seen them in this group of patients with cancer predisposition syndrome before they have any diagnosis of neoplasm or cancer. So sometimes they have already portraying actually clue of this syndrome from the family history, or even some non-oncological clinical features they have, like symptoms of signs, which I'm going to show you in the next slides. So this picture actually shows you some of the non-oncological clinical features that you can see in the patients with cancer predisposition syndrome. So so it's not unusual for, say, our dermatological colleague to see very common eczema, and also some hypopigmentation, and also pilometricoma, and then in fact they are actually related to a cancer predisposition syndrome. So similarly, for our orthopedic colleague to see tibial dysplasia or any skeletal deformity, and also for our gastro colleague to see cow's milk intolerance on GRD or gastric GI polyps, and then also for, say, our pulmonologist colleague to see pulmonary fibrosis. And then those patients with these features might suggest an underlying cancer predisposition syndrome, especially when they have a significant family history as well. So there are also guidelines and also criteria to actually help us to actually make an initial suspicion of this syndrome. So this is a general one for patients with childhood cancer. And this is more specific for replication repair deficiency. But generally, if you look at those criteria, those criteria are none other than features looking at family history of malignancy, and also personal history of cancer or family history of cancer, clinical features like what I mentioned just now, as well as things like consanguinity here. So you may actually argue, why do you need to actually know this very, very early? Because anyway, they are going to have one cancer, and then subsequently another cancer, and then ultimately another cancer, which leads to ultimately early demise. But this is exactly also the area that I would like to actually convince you that is actually very, very important here, because it has actually a huge treatment implication on the primary tumor. Apart from that, also it helps with early detection from family, from cascade screening, and then from that we can actually do early surveillance for the patients and also the family, and then also that helps to also manage some of the non-oncological associated conditions. And then with the known diagnosis, we can have a bit of international collaboration, which I'm going to show you how that will help our patients. And then hopefully in the future, we hope with this known mutation, we hope that we can actually intercept them early, and then have a primary prevention, meaning that we can actually prevent the tumor from even happening, not just talking about early detection. So in terms of treatment implication, if you know there's actually a certain mutation in the tumor, then we can have sometimes targeted therapy for that specific tumor. And then sometimes when you know this cancer predisposition syndrome, sometimes it is related to DNA abnormality or replication abnormality. Sometimes we might need to actually adjust our chemotherapy or radiation. Obviously, in case of patients that we consider for a transplant, definitely we do not want to actually transplant the patients with a donor with a known mutation as well. So this is a rationale really for us to actually know this mutation in this patient with cancer. So just to give you some of the examples, so this is a condition called replication repair deficiency. So the main problem happens in the proofreading gene of of it. So basically, you know that generally when we have DNA replication, inevitably we have actually errors actually happening. But thanks to these proofreading genes, that helps to actually correct everything. But when we have this RRD or replication repair deficiency, so things happen when the mutation was not actually is not corrected, and then therefore with the accumulation of this mutation, ultimately patient actually develop cancer. So in this RRD, literally patient can have tumor everywhere, just anywhere. And then sometimes they can even have synchronous tumor, whereby they can have tumor in different locations with different histology. That's the scary part of this condition. So, but now we know that with this abnormality in the proofreading gene, now we know that we have immune checkpoint inhibition, and you can see this arrow by acting on this PD-L1 and PD-1 connection, we can actually get the T cell to actually attack the tumor cell and leads to tumor cell death, and hopefully that will lead to a good outcome, which I'll show you later. So you can see that in patients with RRD, replication repair deficiency, with a very aggressive brain tumor called glioblastoma, you can see that conventionally, if let's say they receive chemotherapy and radiotherapy, the outcome is really, really poor. It's almost non-salvageable, and then in case of recurrence, it's really that they won't actually survive. But with this immune checkpoint inhibitor from this waterfall plot, you can see that more than 50% of them responds to this medication. And then from this, you can see the swimmer plot that they actually survive actually a long period of time, up to even 40% of them. So sometimes this immune checkpoint inhibitor is also useful to treat synchronous tumor, different tumor at one go. So it's really, really useful for us to actually know this diagnosis and the underlying mutation for us to understand it. So in another diagnosis, tuberous sclerosis. So in tuberous sclerosis, sometimes patients, they can have this thing called SEGA, or subependymal giant cell astrocytoma, or low-grade glioma. So basically, conventionally, previously, we used to treat them with surgery if, let's say, they are symptomatic. But now with understanding of the mutation, we can use this medication called sirolimus, and then you can see how effective it can be to this type of tumor with this sort of mutation that we know. So similarly, in case of patients with neurofibromatosis type 1, they can have this tumor called plexiform neurofibromas, and sometimes they are not resectable, and as you can see in the picture here. So when we know more about this mutation in the NF1 pathway, and then we know that we can use this medication called selumetinib, and you can see that definitely the effect is actually very, very good, and then it definitely helps to actually reduce the tumor load. And then you can see on this graph here, the natural history suggests that the plexiform neurofibroma will anyway actually progress. The progression-free survival is actually very, very low, but with selumetinib, actually that will definitely actually help with the tumor control here. So this is another example that I'm actually showing you that knowing a cancer predisposition syndrome is going to be very, very helpful in actually limiting or avoiding some of the treatment that can actually cause serious complications. So this is a patient with a 4-year-old medulloblastoma. So conventionally, usually we will treat them with radiotherapy and also chemotherapy. But in patients with Gorlin syndrome who has a high tendency of developing basal cell carcinoma, radiation is actually contraindicated. So in this patient, unfortunately, Gorlin syndrome was not picked up initially, and then this patient retrospectively noticed to have jaw cyst, which is classical for Gorlin syndrome. Ultimately, this patient unfortunately developed basal cell carcinoma because of the exposure to the radiation, unfortunately. So another example how by knowing clinical diagnosis of cancer predisposition syndrome will help in prognostication. So give you an example, 14 years old medulloblastoma, average risk medulloblastoma, generally the survival is actually more than 85%. But however, if let's say, for example, in this case, this patient has a significant family history, and ultimately this patient was diagnosed with Lee-Fraumeire's disease syndrome, this patient has rapid recurrence and also death. So in this case, this CPS diagnosis directly actually impacts the cancer outcome and prognosis, and then that actually change how we need to actually talk to family in terms of the prognosis of the patient in a so-called like conventional oncology diagnosis that we used to know. So it's very, very important here when we know the mutation in the index case, then we proceed with cascade screening to actually pick up family members who are actually asymptomatic or pre-symptomatic. So it's actually very important, therefore, to actually refer to our genetic colleague for a genetic counseling, and then subsequently to actually perform tests to actually pick up those patients with clinical cancer predisposition syndrome. So this is an example of the benefit of doing this cascade screening. So in this patient, sibling number 1, this patient has a choroid plexus carcinoma, and then this is actually a sentinel cancer for Lee-Fraumeni syndrome. So this family is known to have Lee-Fraumeni syndrome, and so therefore we actually proceed to screen the sibling who is actually asymptomatic. And then you notice that there's also a tumor here. So in this particular situation, I would not say that ultimately this might change the outcome of this patient, but definitely you can see that by noticing this earlier, the surgical morbidity is definitely going to be actually smaller if let's say you need to actually go in and resect this tumor. So again, you will argue that why do we need to actually pick them up earlier, as what you actually mentioned. They will have cancer, another cancer, and then subsequently multiple cancers, and ultimately that will lead to death. However, there are actually more and more reports suggesting that when we actually detect this nasty syndrome, we can still actually ensure them a fairly good overall survival. So this is a work from the Canadian group looking at patients with Lee-Fraumeni syndrome. With this series of this established surveillance using imaging or scopes, you can see that the red line, those patients with surveillance significantly actually survive longer than those without. So this is another example for patients with replication repair deficiency. So you notice that if we do surveillance early for them, you can see the blue line, the overall survival is obviously higher. Even if you do just partial surveillance, the outcome is actually significantly better than those without. And then we are talking about 12 years here. We are not talking about just 1 to 2 years to this nasty disease, which basically they can have cancer just in everywhere. So remember just now we talked about tuberous sclerosis, and we can use this medication called sirolimus to actually help with this low-grade glioma in the brain. So sometimes they can have also some non-oncological conditions such as seizure in tuberous sclerosis, some cognitive impairment, and also some neuropsychiatric manifestation. And then more and more reports showing that with the same medication of sirolimus, we can actually use them to actually control those situations well. That can actually help to improve the cognitive function and also seizure control. So when we know certain diagnoses, especially the cancer predisposition syndrome, or at least we suspect that, so sometimes it's actually helpful to actually connect with the international group. So this is an example of it, International Replication Repair Deficiency Consortium from the Canadian group. So basically what happened is that when you suspect this sort of disease, you can actually connect them, and then they will, sometimes what you can do is even you can actually send them sample for them to actually help you to make the diagnosis for free. Really, sometimes they just need the data, and then sometimes after that they can have a multidisciplinary team meeting for your patients with all the images you have, and then advise the treatment accordingly. And sometimes they might even get you to connect with a pharmaceutical company to actually help you to get certain medication that's important for the treatment of the patients with cancer predisposition syndrome, in this case a replication repair deficiency. So with all this knowledge, of course, I think in the future we really hope that we can actually do primary prevention, meaning that before even the cancer happen or neoplasm actually happen, we can actually intercept that. I think that's the idea now we have, and then you can see that there are different actually effort looking into that, though I must say that there's so far no practical use so far for now. So knowing that also, I think we need to also have caution in this by not just screening them without a good genetic counseling, because it has obviously ethical issue, especially if let's say you are screening patients of minor age, like children. Of course, you need to also understand some of the psychological stress to the family, and then sometimes it will even cause insurance discrimination. So it's actually very, very important to therefore involve our genetic colleague to actually get them to help with the genetic counseling. So with that, I will just summarize the talk this morning. So oncological diagnosis, when you have it, it might not be the final and full diagnosis. So at all time, let's remind us to actually look for underlying inheritable cause. And in this cancer predisposition syndrome or genetic tumor syndrome, they are not uncommon. So the detection usually is retrospective, where we make a diagnosis of this oncological diagnosis, and then we look retrospectively to see if, let's say, that there's any inheritable cause to it. Sometimes they have clinical features with non-oncological features suggestive of that, with family history as well. So therefore, that should actually prompt us to actually send investigation to look for that. We discussed about the implication of early detection just now, and then I just like to actually need to highlight you once more that early surveillance is very, very important, and that really can actually help them to have a better overall survival. And then last but not least, genetic counseling will be very, very important for this group of patients before we send any form of investigation, because it has actually huge implications to the family and also other aspects of life. Okay, so with that, I thank you, and then I would like, I'm okay to actually take any questions if, let's say, there's any. Thank you so much.
Okay, thank you very much, JC. So we'll open the floor to questions. We'll start with a question from Prof. Sarah. She says, is there any effort to try and amend the gene of interest? Perhaps we'll just choose one, maybe TP53. Are you aware of any work to try and amend that?
Okay, I personally, not that I know of for now for this like a gene therapy for this specific gene as far as I know, but I know that there are definitely some effort to actually target this P53 actually, but so far from the Canadian group by the guru from the Lee Pharmacy, Dr. David Morkin, I think the group, they are actually trying to do that. But so far, I don't think we have actually established data yet. I think they're still running the trial. But let's be hopeful for that. I think that will be something very, very significant for us to have that. Yeah.
Okay, I think just to add to that, for at least for childhood cancers, P53 mutation is quite rare, seen in about 10%, as opposed to in adult cancers, where 50% of those cancers have a mutation in P53, a somatic mutation. And so that's why we are, in fact, our team is looking at the possibilities of the role of isoforms of P53, because P50, the total protein is intact, but yet the function is abnormal. So maybe I can ask a question, JC, with regards to the Toronto protocol. I, in fact, had a chance to speak to Dr. Malkin about this in a conference before, about the feasibility of doing this, especially the pickup rate. Children have to undergo sedation, to undergo MRI. What are your thoughts about this in this part of the world?
Okay, let me maybe go back to the slides. Okay, I'll go back. Okay. Okay, this one. Yeah. So obviously, I think, okay.
That's your slide.
Yeah. Okay. Yeah. So obviously, I think some of them are actually invasive. I mean, at least we'll need some form of maybe sedation and everything, as what Prof actually mentioned, and then some of them might even need maybe a scope or something like that. So I think it's therefore actually important to, of course, first make a confirmed diagnosis from the genetic point of view, as compared to just a clinical diagnosis, and subsequently, I think the communication with the family is actually therefore very, very important. I think it's also important for us to also collect more data, especially for pediatric age group, on how soon they will actually develop all this cancer, and then therefore rationalize the schedule for all this investigation, especially those the invasive one. For example, not maybe in this case, for example, like replication repair deficiency, for example, they know that the colon cancer will happen later in the age, so they will actually screen later, but not say like a infant or a younger age, for example. So, and then subsequently, I think it's also important to actually talk to family and communications. That will be very, very important for them to actually understand the rationale behind it, so that they will actually allow and also give consent for us to actually proceed with this test or investigation, which also sometimes carries complications. Yeah.
I think that's a tricky bit because of, for example, colorectal carcinoma happens in infants, and yet infants to get them to have a brain MRI as a surveillance tool is very difficult. And also added to that is the discordance between genotype and phenotype. So not necessarily a sibling who also shares the same p53 mutation may manifest the same phenotype. So very, very difficult. Perhaps another comment about insurance discrimination in this country with regards to inherited predisposition syndrome. What are your thoughts on that? Your personal thoughts?
Yeah, I think it's very, very tricky here, because every time when we need to actually send this, counsel them to actually, I mean, of course, to start the initial conversation about sending this test, of course, I have to say that most of the time we need to actually refer to our genetic colleague to have a proper genetic counseling. Always the first question from them is how would that actually affect the insurance coverage? I think that's a very, very tricky question, and also practical, because the moment we make a diagnosis, most of the time the insurance won't actually cover this. So I guess in this situation, most of the time, to be very honest, I'll still actually refer to the genetic colleague. I think there'll be tricks that we can actually do this by thinking first how in this diagnosis at this point of time when we make a primary oncology diagnosis, how will that change our management, and subsequently also tailor or think about the timing of this test. I think that would be very, very tricky. I think, of course, it's also difficult to actually discuss and how we need to actually disclose this to the family and also to the insurance company. I think this is a very, very tricky situation, usually which I will actually refer to our genetic colleague to also deal with it together, to discuss how will that affect the big picture for this patient. Yeah.
I think we should lobby our politicians to pass an act against discriminating people who have a genetic predisposition to disease. I think it's a form of ism. So we have a question also from Dr. Tay Sok Poon, who is our genetics consultant. She has asked what challenges do you face in the interpretation of somatic versus germline variants in genetic testing?
Okay, so I think generally, because somatic, usually we first notice it from sequencing the tumor. So then after that, when we have that, then we proceed with germline testing from generally the blood. But sometimes it's just really also from the tumor sample. We can sort of like suspect that as well. For example, when you stain, for example, just now the MRR protein that we stain the tumor cell, and then we notice that the normal cell also has an abnormal staining, and then from that, in a way we know that maybe there's also germline abnormality in it, and then we proceed with germline testing. Similarly, for p53 protein, we have loss in the tumor protein, and then this tumor protein, and then subsequently the normal tissue as well. Then we have this suspicion. I think for that, then we will sort of like know that, of course, we send off the blood for germline testing, then we finally get the diagnosis then. Yeah.
Okay, thank you. Just one correction. In people who have p53 mutations in the immunohistochemistry, the p53 is overexpressed rather than lost.
Okay, sorry, Prof. Yeah, sorry, overexpression. Yes, Prof. Yeah.
Okay, so that brings the first part of the morning to an end. So I'd like to congratulate Dr. Fu. We were very happy that he's come back to take care of the brain tumor patients who are very, very challenging, and to try and find new solutions for patients that for a long time we said palliative care cannot do anything more. But with the advent of new targeted therapies and understanding of biological pathways, there is a lot of hope in the near future. So if I can hand over the floor to the next chairperson,